Good morning. Thank you, Chris. It's a distinct honor and privilege to be with you this morning. As Chris mentioned, if I can get the slides here to work, I was asked to speak about some of the work that I did when I was with the federal government and the VA healthcare system in the latter part of the 1990s. I should make clear that I haven't been with the VA for over a decade now, and much of my work currently involves many of the same issues as far as integrating care and quality improvement and whatnot, although it's mostly focused on other publicly funded programs, Medicare, Medicaid, and with the private sector. So what the intent is in the next 25 or 30 minutes or so is to provide a very brief overview of what happened in the VA. I know many of you are familiar with at least some parts of that story, but I'd like to spend most of the time on highlighting at least some of the experiential observations about achieving integrated care. And I would preface this by saying that achieving integrated care or clinical integration really is essential to most of the strategies now that are focused on improving the overall quality and efficiency of care, particularly for those who have chronic conditions and more than just the episodic need to indulge the healthcare system. I would also just make one other caveat that over the last 25 years or so, I've had the opportunity to work with healthcare systems in numerous countries around the globe, essentially on all the continents. And I'm very mindful that trying to extrapolate from one system to another is fraught with danger, although I'm also impressed that many of the challenges and issues are similar, and many of the principles may be applicable across national borders as well. So let me start with just a very brief overview of the VA healthcare system. The system is one that's managed by the Veterans Health Administration, which is a sub-cabinet agency in the U.S. Department of Veterans Affairs. The Department of Veterans Affairs is the second largest agency in the federal government in the U.S. next to the Department of Defense. However, the VA or the VA healthcare system is totally separate and distinct from the military healthcare system, and that's a nuance that's often not understood. The Department of Defense also runs a very large healthcare system as well. VA was established in the early 1900s. Like most everything in healthcare in the United States, it didn't happen at once, but it happened over a series of events over the first three decades of the 20th century, and then there were several other major changes subsequently. It's somewhat ironic in that a country where most healthcare is market-based and in the private sector, actually the largest healthcare system in the country is the VA, which is a centrally administered, fully integrated system that's both funded and care is provided by government and employees. And it's actually the only national system insofar as there are VA facilities in every state, every significant metropolitan area, as well as in a number of places outside of the United States, such as Guam and Samoa and the Philippines, other places where there are significant populations of U.S. veterans. It's somewhat unique in that it also functions as both a payer and a provider. It runs about a $6 billion a year insurance program. It's very extensively involved in health professional training. Some 47 different types of health professionals train at VA facilities each year. About 110,000 trainees of various flavors rotate or receive clinical training at VA facilities. 85% of VA hospitals are teaching hospitals. And it's also quite a large research organization. Currently has a research budget of about $2 billion a year. It's hard to pick up any issue of New England Journal or JAMA and not find at least one article by VA investigators. Perhaps most notable to this discussion is that the population that the VA serves is significantly older than the U.S. population. It is much sicker, poorer, less well educated. Overall is a much more medically complex population to take care of than the general population. And there is an especially high prevalence of multiple chronic conditions, and ergo one of the reasons why integration of services was so important, because of both the disease burden, the number of comorbidities, as well as the social needs of many of the beneficiaries served by it. And the last gives you some sense of current size. Last year, the system had about 235,000 employees, a budget of $47 billion, and it served about 8.5 million individuals. The problem in 1994, when I accepted President Clinton's offer to head the organization, which I must say that all of my colleagues advised me not to do because they felt it was a career ender. But there was surprising unanimity of agreement about the problem list. And this actually is not surprising, as it's often far easier to identify the problems than the solutions, of which there was no agreement at that time. But care was quite fragmented, uncoordinated, was very hospital-centric and specialist-based, often long distances, long waiting times to get care. Quality was, I think, charitably irregular and unpredictable. Costs were rising, very bureaucratic, reams of policies and procedures, which by and large frontline caregivers did their best to ignore. The organizational culture was highly punitive, risk averse, not altogether surprising insofar as the amount of, it's a highly politicized environment, and when one made a mistake, the consequences were often much more than just getting fired or something. You see yourself on CNN or C-SPAN for the nation being ridiculed by elected officials. So it tended to stifle innovation or doing things differently. Leadership often changed and was selected for reasons often not related to healthcare competency. Overall, everyone was unhappy. The staff were demoralized, patients were unhappy, the Congress was unhappy, and there was no agreement about how to fix the problem. So it's somewhat ironic that if we fast forward 10 years, headlines like this in periodicals that traditionally don't say anything good about government, we're actually writing quite favorable articles about what had happened in the VA and how it had turned itself around. And so I'd like to take the next few minutes just highlighting some of what was done at a very high level to turn the system around. And as with most things like this, it starts with a vision. And the vision that was espoused at that time was as noted here, but basically it was focused on improving quality, providing a seamless continuum of care, and one in which it was easy or clear to document that it provided superior value and that care really was patient-centered. The strategic objectives were basically, as noted here, we wanted to increase accountability. One of the ironies of the system was that despite all of the bureaucracy and oversight and reams of policies and procedures, it was an incredibly unaccountable organization. So there was an overt effort was made to increase accountability. We wanted to integrate and coordinate care, again, particularly important given the disease burden and the social problems that so many of the beneficiaries have. We wanted to improve and standardize high quality so it was predictable and consistent throughout the organization. Modernizing information management was not necessarily a goal in and of itself. It was a tool or a means by which we could accomplish these other objectives. And then finally, the last was simply to align the finances with the desired outcomes. Even in publicly funded systems, if the financial alignment is not correct, it's not going to support any sort of transformation. Finances or money is the universal elixir, and that piece of it had to get correct along with other parts of the strategy. Again, a very high-level overview of what was done. Some of the major elements of the transformation included creating a new management and operating structure that was overtly designed to increase accountability as well as to support or to facilitate the integration of services across the continuum of care. Wanted to increase attention to population health and really started to focus on health promotion and disease prevention, which many people found quite counterintuitive in a population with such a high disease burden. Why would we be focusing on health promotion? And granted, it was mostly secondary and tertiary prevention, but the more we could keep people healthy and functioning and out of the hospitals, I mean, hopefully one doesn't have to argue too hard to make that case. One of the foundations and the first strategic efforts was to implement universal primary care. At 1994, at the time I went there, about 10% of patients were enrolled in a primary care. Given the very close connection of so many VA hospitals with academic health centers, it perhaps is not surprising that primary care was not nurtured in the organization. And indeed, we embarked on an initiative that over 4 years put in place essentially universal primary care. Actually, we used more of the British firm model than the American family practice model and focused, most of the primary care practitioners were general internists for a number of reasons. Put in place a new performance management system with standardized system-wide performance metrics and actually negotiated performance contracts, which I negotiated with each of my network directors, and they in turn with the hospital and other subordinate managers underneath them. Implemented a system-wide electronic health record. Indeed, I think the implementation of VISTA in the VA remains the largest and most rapid deployment of an electronic health record anywhere to date. Went fully implemented at 172 hospitals in less than 3 years. Implemented, importantly, a new capitation-based global payment system that was not the traditional one-level capitation, but it was a multi-level cap rate, and focused a lot on decreasing hospital use, increasing ambulatory care capacity, moving care out into the community whenever possible. Established a national formulary more as a quality improvement method than as a cost control mechanism, and did a number of other things, but I think you get a sense of some of the major strategic efforts that were put in place. I just want to focus briefly on the VISNs, the Veterans Integrated Service Networks, which were the new budgetary and operational unit of the organization, in which they encompassed a defined population in a defined geographic area with the intent that they would be able to provide a continuum of primary to tertiary care with VA assets. And in some cases, this encompassed a fairly large geographic area, particularly in the western part of the United States, where there's often a lot of geography and not many people in between. And they were based on patient referral patterns and other patient-centered criteria, which sometimes resulted in some interesting political dynamics when states were cut into multiple regions, but that's perhaps a topic for another conversation. The networks were responsible for providing comprehensive care, managing the total cost of care, and while they were expected to provide a continuum of primary to tertiary care, many of the specialized services, spinal cord centers, other centers, really were not able to be in each VISN, so there were referral relationships and other relationships for some of the highly specialized care. And I think the networks have provided an interesting laboratory for clinical integration over the last 15 years or so that they've been in effect. This is just a map which shows the 22 networks that were established initially. There was nothing magic about 22, it just happened to meet it was a pragmatic way of balancing the multiple different criteria that were used to establish them. A typical network had somewhere around 8 or 9 hospitals, a large number of clinics. That number has markedly expanded in the years since. a number of long-term care facilities or nursing homes, social care here, quite a number of freestanding counseling centers that the VA has, particularly focused on for veterans who have PTSD. And then typically one or two very large residential care facilities for persons either with chronic mental health needs or substance abuse, or I should say, and/or substance abuse problems, and that had a difficult time residing on their own. Just a quote from the document that actually the change in organizational structure required congressional approval, and so we actually had a document that went through, but I just highlight this because it made the point very explicitly that the role and the expectations for hospitals was going to change, that they clearly would be, as they have to be in any healthcare system, an important part of it, but the system was going to be less hospital-centric, and that hospitals would be part of integrated networks of ambulatory care and acute and extended care services of various types, with the overt intent to provide a coordinated continuum of care. So with that, let me shift gears perhaps and focus on a number of observations I think that have accrued from the experience of the networks over the year as far as achieving integrated care. And again, I'm mindful that what is observed here may or may not be translatable to other settings, although there may be some common principles or observations that are relevant. And I guess before I go further, I should say a word about what is integrated care and how we thought about it. And I think the three key words are comprehensive, coordinated, and continuous. And that would be strategically and overtly designed into the system. It wasn't a happenstance or a side effect, but it was something that was strategically designed into the system, and we would do that by using a variety of tools and tactics and strategies, from performance assessment, using quality benchmarks, using different types of advanced communications and information management technologies, practice guidelines. You go down the list of other tactics to achieve this. The first observation I would note, and I think it's perhaps one of the more important ones, is that achieving integrated care is more a sociological phenomena than a technological one. So much of the discussion today is focused on electronic health records and all of the processes and technologies, but fundamentally none of that stuff works if you don't have the right culture and the right environment for this to take hold. It really is very much of a sociological thing. And then we can look, why is healthcare culture, how did it get to where it is? And I won't take the time to go through this, but there is a long list of reasons why over the 20th century healthcare has developed a culture that is really averse in many ways to integrated care. And as we think about how we achieve this, we really have to think about some new ways of thinking, some new competencies if this is going to be successful, and beginning with systems thinking. And I always find this somewhat ironic because so much of healthcare teaching is based on organ systems and physiologic systems. But then when we move to the delivery of care, we seem to forget about these principles of how systems operate in the aggregate. But we really need to extend that to the delivery processes as well. The science of teamwork and collaboration, and there is robust literature that one can draw on, largely from outside of healthcare, quality management and the whole process improvement science, information management and different types of that, how we look at it, understanding complexity theory and the fact that healthcare really is governed on the basis of chaos theory and not the more linear manufacturing ways of thinking. Viewing hospitals as cost centers as opposed to revenue centers, and that may not be as applicable here, but in the U.S., historically hospitals are viewed as revenue centers, and we really have to do a 180 there and start viewing them quite differently. And viewing admissions as something that are tangible manifestations of system failure in many cases, which again is exactly opposite of how they're so often viewed today. And perhaps the second observation I would put on the table is simply that there's no single pathway or universal model to get to integrated care. Certainly having a vision and shared aims are important, but even in a system such as the VA, which is one might think is really homogeneous, if you think about how you're going to provide care for the population in Manhattan, New York, or in Los Angeles, and those are two quite radically different populations, although both highly urbanized areas, versus Alaska or Montana, I mean, it starts to become clear that the same aims and goals have to be achieved by somewhat different means. And then when you go across boundaries in other countries, again, there are common aims, but those really have to be tailored to the local circumstances and conditions. I think that some of the common aims are as noted here, but in the interest of time, I think I will bypass this, but it largely again goes back to rethinking what we're doing and the approach to providing services in a much more coordinated and convenient manner for our patients. A third observation is the essentiality of having strong clinical leadership, whether that leadership is as the CEO or as a chief medical officer or other. But so much of this does require clinical leadership, and I know in the US that is an area which is not always in adequate supply, one that we're trying to build capacity in, and I suspect that's not altogether unique to the United States. But I would also make the point that leadership is often viewed as somewhat ethereal or non-specific. But certainly in this realm, there are very specific things that leaders and clinical leaders need to do, such as being able to articulate a vision and stay on point, to focus on that long-term vision, recognizing that in any real-world situation, there are circumstances that come up every day that are very distracting. And by the end of the week, you're totally distracted from the long-term view. And one of the essential roles of leadership is to maintain that focus, to be the bridge between the boardroom or the governance and the front line and vice versa, be able to translate the different needs and views in those two settings, to build and sustain trust. That's one of the most difficult things I think that we find is trust between physicians and hospital leadership, between the different types of providers, between the payers and the providers, and of course there are differences here, but again, one of the key roles of leadership is finding ways to build and sustain that trust. There are always competing demands. One can never has enough resources, never has enough time to do everything that's expected. So leaders are the ones who have to prioritize and make the choices about what we focus on today, what we focus on in the short term versus the long term. And there are a number of other things, as noted here, that I would just say that these are very specific requirements of leaders that many often don't appreciate when they step into those leadership roles and then find that their tenures aren't always as satisfying as they should be. The fourth observation is simply one that I alluded to earlier, that finances have to be aligned with the desired outcomes. That alignment can be achieved in multiple ways. In the US right now, we're seeing multiple different strategies being pursued, from bundled payment to global payment under accountable care organizations, pay for performance, and a number of other strategies that are steps to some sort of financing mechanism, which in the future will look quite different than it does today. I would also note that while I can't point to science or hard evidence, it has been my impression that often removing the financial disincentives for integrating care may be more important than actually putting positive incentives in place to do it. And again, focusing more on the other side of the Atlantic, there are all kinds of financial disincentives built into the system that erode any attempt to integrate care. And many professionals would be get on this board very quickly if those disincentives were removed, and they would be much more responsive to being able to do what makes sense for their patients if the financial incentives were such that they could do that. Just reflecting back on the VA, a couple of factoids here. We did obviously focus on reducing our annual operating costs, even the GAO, which historically doesn't say anything nice about government because they're paid to criticize. Agreed that we had reduced our annual operating costs by over $1 billion a year in this 1 3-year period. We were able to document by going with the National Formulary, which was again designed to be primarily a quality improvement formulary. But by doing that, the purchase price on drugs was reduced by over $650 million a year. Those are 1990s dollars, a bit more than that. We focused on getting rid of a lot of the bureaucracy, eliminated almost 3,000 forms of various types, automated the rest, which means that we were still left with too many, but it was a step in the right direction. And we're able to document that the annual per patient expenditures decreased by a little bit over 25% a year. Fifth observation is simply that integrating care requires new tools and an enabling infrastructure. And this is where much of the conversation is today. These are things which I know you're familiar with. Many of the technologies from electronic health records in the hospitals, health information exchange in the communities, decision support, registries of various types, the performance management systems and all the performance measurement and the often controversy associated with performance measurement, the different care management tools. Just as a slight digression, in the VA, it was always interesting to hear the disease management vendors come and talk about their latest and greatest module for taking care of, pick a condition, emphysema or asthma or whatnot. And then you would ask them, that's great, but what do you do about their ischemic heart disease and hypertension and congestive failure and pancreatitis and diabetes and schizophrenia and there are 8 other diagnoses. And so we really have to focus on increasingly total care management. And sometimes those can be bundled along certain lines, like cardiovascular disease or whatnot. But it's a much more complicated than most of the disease management vendors, I think, would lead one to believe. Focus on teamwork, clinical guidelines, educating and training people for new competencies. Again, one of the areas where I think many systems fall short in trying to integrate care is that they expect people to perform in new ways and have new competencies, but they don't invest in bringing them along to the point where they have those skills and they have those competencies, which certainly in the clinical arena, they've never gotten anywhere in their training. And so this actually has to be overtly designed into the system, and it also comes with a cost. Which is always a challenge in the public sector because these types of things fall under administrative costs and everyone wants to reduce administrative costs and focus on the clinical side. So I know that was one of our continuing challenges, is how do you build in that type of necessary training at the same time reducing costs. Mindful of the clock, let me just move forward, but I would be remiss if I didn't point out that there is now a substantial number of papers that have led to rather disappointing results when attempts at integrating care using all these new tools, and they found they weren't getting what they had hoped for. And so I would go back to you have to have that infrastructure of technology and processes, but it's only going to be effective, those tools will only achieve the benefit if in fact they are embedded in a culture of collaboration and quality improvement. that really, it goes back to this idea that this is in many ways sociological, and we have to change the way people think if we're going to take full advantage of the infrastructure. Strategic communications plan is an essential part of this. It's one that is almost universally overlooked. But whenever one is embarking upon a major change effort of any type, including trying to integrate care, there is need for strategic communications. This is not public relations, but it is strategic communications. Some of the things that we've found key to this is having the message very defined, using the right messengers to deliver that, and typically nurses and physicians are better at delivering this message than our administrators or government officials or others. The need for it to be culturally appropriate and health literate. Also, in the healthcare setting, we often forget that in a 24/7, 365 operation like healthcare, there is a substantial part of the workforce, particularly those who work at night, who aren't interested in hearing some of the usual communication strategies when they get off work, and that we have to design and be able to deliver messages that are appropriate for the entire workforce. A seventh observation is simply that if one really focuses on and achieves integrated care, there will be a need to restructure one's assets. And restructuring one's assets is perhaps code for meaning less hospital capacity and more outpatient or ambulatory care capacity. In the VA, during the 5-year period that I was there, we closed 55% of our acute care beds, about 29,000 acute care beds, reduced our staffing by a significant number, even though the actual relative proportion of caregivers increased. Some of that was possible by merging facilities that were nearby into multi-campus, single administered facilities. We opened more than 300 new community-based clinics, and I would say that we actually had no appropriation to do those. All of the funding to support the new community-based clinics was achieved through savings in other ways, such as closing beds and in some cases closing facilities. We reduced our inpatient admissions by more than 350,000 per year. It went from about 1.1 million admissions per year to a little over 600,000. And reduced bed days of care by more than 68%. And actually, despite the acuity of illness and the other sociological issues of our population, ended up with a rate that was about 10% less bed days of care than the Medicare population, which is, at least age-wise, a comparable one. Then implemented a number of telehealth and other virtual healthcare strategies in addition to other ambulatory care capacities. Again, a caveat on this that while we have to restructure our assets, we also have to be mindful that hospitals serve other purposes than providing health care. Not the least of which is they are major employers in every community. So when you talk about closing hospitals or reducing hospital capacity, you in essence are talking about cutting jobs, which is something that the elected officials always cause their sphincters to tighten. In many communities, hospitals are sources of identity, community identity. And when they lose their hospital, they feel like they lose their vitality. And so in thinking about this restructuring, we have to be mindful that there are other roles of hospitals than just healthcare. A point that I think I've already made is understanding that healthcare operates as a complex adaptive system, which basically means you can't specify and dictate the change the way that you would in a more linear manufacturing model. I'm not going to go through all this, but complex adaptive systems have a different set of characteristics, not the least of which is perhaps the last one, that there really is no single point of control. Sometimes people delude themselves into thinking that they actually have control over it, but the reality is that there are multiple foci of control. Systems learn and adapt. And instead of thinking about change in the way that you might think about a more linear manufacturing process, we really have to think about what are those critical change levers. what are those things where if we make relatively minor adjustments will amplify and produce larger change and can be leveraged throughout the system to produce the desired change. You know, payment is one of those. Performance measurement might be another, and there are some other those critical change levers as well. Just two more points, and then I'll call it a day. The last one is that there will always be unintended consequences. It is something that has to be recognized, and it has to be designed into the system to understand, because healthcare operates as a complex adaptive system, there will be unintended consequences. It's inevitable, so one has to design in systems of vigilance to try to pick those up before they either harm too many people or waste too much money or cause other sort of political complications. And likewise, there has to be a course correction mechanism built into the strategy, because it is certain that one will have to make course corrections as one moves forward with the implementation. And finally, the last point is simply that it's hard work. For some of the things that seem no-brainers, should be straightforward, they're always more complicated. It always takes longer than one would hope, which is one of the reasons why, at least in my approach, we set very aggressive timelines, knowing that they're always going to take longer than one hopes, just because it's not as easy as one might think. With that, I thank you for your attention, and we'll move forward, I guess, to questions.